Okay, we're going to start the second session now. So I'm pleased to begin the second session of this conference. The title of this session is The Changing Context. And for this session, our first speaker is Phil Landrigan. And many of you at Boston College know Phil. Phil is the director of the Global Public Health and the Common Good program at Boston College, and he's director of the Global Observatory for Pollution and Health. Phil is a pediatrician, a public health physician, and an epidemiologist. And he has over 700 scientific publications in his long and wonderful career. So we're going to ask Phil to come up and speak for about 20 minutes. And I will note that I do have information cards with time on it. So I'm not the person who has to remind folks if you're going over.
Good. Yeah, I know how to work that. Yeah. Okay, I'll do the Joe Biden thing and take off my mask while I'm speaking. So thank you, Laura. Thanks very much. Let me join my colleagues, Tom Childs, Andrea Vicini, and Kurt in welcoming you to this program. This is actually the second conference in a series. 2 years ago, at the time we launched the minor in global public health and the common good at Boston College, Andrea and I got together and organized a conference called Ethical Challenges in Global Public Health, Climate Change, Pollution, and the Health of the Poor, which has come out just in the last few weeks, actually, this book, which we published. And the plan is that the presentations from today will appear in a similar book in the same series by the same publisher. And this is a tradition we hope to continue going forward into the future. So you've heard from our speakers this morning. You've seen the statistics of the disparities in cancer. When I was at Mount Sinai Hospital in New York City, where I was for many years, and there's a couple of Mount Sinai colleagues with us today who are going to speak on the program, including Roger Flores right after me, and then Misha Shafir later in the day. My boss was a man named Irving Selikoff, who did some of the seminal work that related asbestos to cancer. Dr. Selikoff used to say that statistics are people with the tears wiped off. I think it's a simple line to hold in your mind as you go through this day. We're looking at these complicated statistics, graphs, charts, but bear in mind that every dot on that chart is a person, and each of those persons is part of a family and part of a community. And when cancer strikes inequitably and in disparate ways in society, it's hitting people, it's hitting their families. So in the preceding talks, we've looked at the mega picture, the differences in cancer rates, the differences in mortality from rich to poor, from global north to global south, from black to white, from majority to minority populations. What we're going to start to do now is dig into what are the specific factors that account for those differences. We know the differences are there. What drives them? And one of those drivers is pollution of the environment by toxic chemicals. And that's what I want to talk about in my little talk this morning. So, by the way, this is a picture of Cleveland, Ohio, 1968. It's a couple of blocks from the hospital where I did my internship, Cleveland Metropolitan General Hospital. 5 years after I graduated from BC, I was out there in beautiful downtown Cleveland. And this is the kind of air that we had in many parts of the United States just a half century ago. It's the kind of air that's in China and India and some other emerging countries today. We define pollution as this. It's waste material of human origin. So it's not volcanic ash, for example. It's stuff that people put into the environment that harms health and harms ecosystem. And although climate change is not the main focus today, I want to make the point that pollution and climate change are intimately connected. They're joined in their origin, they're joined in their effects. Fossil fuels are the root of all evil here. The combustion of fossil fuels is the major generator of the carbon dioxide and the other climate gases that lead to global warming, and it also is the major source of the principal air pollutants, fine particulates, oxides of nitrogen, oxides of sulfur. And increasingly, fossil fuels are fueling pollution in yet another way, in that they have become the major feedstocks for the production of synthetic chemicals and plastics, which, as you all know from anybody who watches ocean documentaries on TV, that plastic pollution is just enveloping the planet. And that's just another manifestation of our reckless extraction of fossil carbon from under the earth. And they all come together additionally in the fact that they all have negative impacts on human health. From 2015 to 2018, just as I was leaving Mount Sinai in New York and coming back here to Boston College, I had the privilege to co-chair this publication, the Lancet Commission on Pollution and Health. Lancet is the world's most widely read medical journal published out of London, and they helped us to put this thing together. This was the main finding from that analysis, which involved approximately 50 people from around the world, including Gautam Yadama, who is the Dean of Social Work at Boston College, Tom Childs, whom you heard from earlier this morning, our Vice Provost for Research. Pollution kills an estimated 9 million people per year. If we have time over coffee, I can tell you how we came up with that number, but suffice it to say that we drew it from the Global Burden of Disease Study, which is put together by the Institute for Health Metrics and Evaluation at the University of Washington in Seattle. Pollution is responsible for 1 death in 16% of all deaths around the world, 3 times more deaths than AIDS, malaria, TB put together, 10 times more deaths than war and violence. Many different kinds of pollution, ambient air pollution, which kills between 4 and 5 million people per year. Chemical pollution, which is 1.1 million deaths are ascribed to chemical pollution, but that's almost certainly a low estimate because of many gaps in knowledge about the toxicity of chemicals. There's also other forms of pollution that I won't focus on today, like household air pollution from cook stoves, water pollution, but the real focus today is ambient air and chemical pollution. So let's talk a bit more about chemical pollution. The chemical industry is extraordinarily inventive, and over the past 70 years, really since the end of World War II, the chemical manufacturing industry has just taken off almost exponentially. In this time, more than 250,000 new molecules have been invented. At the same time, world production of plastic has increased. It started a bit later, but has skyrocketed since. Some of you, if you're of my generation, back in '68 or so, you would have seen the movie The Graduate, where the cuckolded father told the young man to invest in plastics. Well, it turns out he was right. So this is the current situation. 235 manufactured chemicals on the face of the earth. These are new materials. These are not stuff that was always there. These are new materials of human origin that have come along in the lifetime of people of my generation. And they're used today in absolutely millions, probably billions of consumer products. They don't stay in those consumer products. They get out into the environment, and they're found everywhere. You can find persistent chemicals like polychlorinated biphenyls, PCBs, in the Arctic ice cap, and they have been detected in the Marianas Trench, 6 miles below the surface of the Pacific Ocean off the coast of the Philippines. Humans are widely exposed to these chemicals. CDC does rolling surveys across the United States on a continuing basis. My friend and colleague Richard Jackson, who's going to be speaking with us later today, headed the National Center for Environmental Health at CDC, was the person who put together this survey, the National Biomonitoring Survey. It detects approximately 200 manufactured chemicals in the bodies of all Americans every day. Low quantities, to be sure, we're still walking around. But the fact that these chemicals are in us, and the fact that we don't know very much about the toxicity of many of these chemicals, in my mind, is cause for grave concern. We're polluting our environment, but we're also polluting ourselves. And the production line for synthetic chemicals is just going up and up and up, with more than 2/3 of the manufacture now taking place in the countries in the world that are least well equipped to control the materials emitted in the course of production. Deaths from ambient air pollution and chemical pollution are on the rise and are on track to double in the next 30 years if we don't do something about it. And it's just as our previous two speakers have said, there's a very strong intersection between pollution, poverty, injustice, with an astounding 92% of all the pollution-related deaths in the world concentrated in the world's low income and middle income countries. And just as you also heard from our previous speakers, even in rich countries such as our own, pollution is closely linked to poverty, structural racism, marginalized communities. All you have to do, for example, is go into New Jersey and see where the pollution is. Go down the Mississippi Delta in the state of Louisiana, and you'll see these shack communities, mostly African Americans, some Native Americans, nowadays, more recently, some Vietnamese, living in these horrible little communities along the banks of the Mississippi River, dwarfed by these massive chemical factories. And this is just a map showing the same thing. So what's the nexus between pollution and cancer? Well, it turns out that we have known for several centuries that toxic chemicals in the environment can cause cancer. The first recorded recognition, at least in the Western world, was in London in 1776. There was a surgeon named Percival Pott in London, and he noticed an astounding incidence of scrotal cancer, cancer of the skin of the scrotum in young boys. These were chimney sweeps, and the story was that the way they cleaned chimneys in London back then was they took these skinny little kids, 9, 10, 12 years old, put a rope around their thorax under their armpits, gave them brushes like you see this boy holding here, and they lowered them down manually into the chimney like coal miners, and these kids scraped the chimney out. Well, the soot got on their bodies. We now know that that black soot contains a class of chemicals called polycyclic aromatic hydrocarbons. You know it as soot. Got into their skin. The British have never been big on bathing, so the soot stayed on their skin and the scrotum, because the skin is folded and everything. The flecks of soot would hang in there, irritate the skin, and eventually lead to cancer. And these kids were dying at young ages, adolescents, of scrotal cancer. Since that time, and this echoes a theme that was made by Tom Childs and also by Kurt, there's been this massive transition in patterns of disease and death around the world. The communicable diseases, the infectious diseases, the yellow line, are going down. Of course, we're having a COVID epidemic this year. We still have AIDS with us. We still have malaria with us. Nonetheless, despite those developments, the impact of the communicable diseases as a force on global mortality has been steadily trending down throughout the past couple of centuries. But at the same time, the non-communicable diseases, which includes heart disease, stroke, cancer, what we used to call chronic diseases, those are going steadily up. This is the epidemiologic transition that Kurt spoke to. And there are a number of specific connections within those broad trends. There are specific connections between various pollutants and cancer. We know, for example, that constituents of air pollution cause lung cancer. And around the world, 40% of all lung cancer deaths are due to air pollution. This is really not intuitive to Americans. We think of lung cancer as due to cigarette smoking, and indeed, in our country, a very high proportion of the lung cancer is due to cigarette smoking. But on a global scale, pollution dwarfs cigarette smoking as a cause of lung cancer, especially in poor countries where people can't afford cigarettes, but they still have to breathe the air. And water pollution, most notoriously arsenic, naturally occurring. Arsenic is a major cause of cancer in parts of the world that I've listed here, and then multiple chemical pollutants, and more on that in the next slide. So we now know that there is a long, long list, and this is only a partial list, of manufactured chemicals that are known to cause human cancer. I won't go into those in detail. You can see the list there, but what has typically happened is that new chemicals are introduced to the market. The chemists find very good, interesting, beneficial uses for the chemicals. Some of the chemicals, of course, do great good. Think of the antibiotics, think of the drugs we use to treat cancer. But other chemicals get out into the environment, they're untested, they're unregulated, they get loose, and then 5, 10, 30 years later, we find that they cause terrible pandemics of disease and death. And the International Agency for Research on Cancer, IARC, is the arm of the United Nations that has been charged with systematically evaluating different chemicals. They have a nomination process, and certain chemicals are then put through very rigorous evaluations, very highly structured. They use only published data, so they don't use secret data that is introduced by the chemical industry. They only will accept information that's in the peer-reviewed literature. They're fiercely independent of commercial interests. And since the program was started almost exactly 50 years ago, they've evaluated more than 1,000 chemical agents. 121 of these have been proven by their standards to cause human cancer, and another 89 are probable human carcinogens. So that's roughly 200 chemicals that we know cause cancer in humans, and then others that are possible, or where there's simply not enough information to make a determination one way or the other. And the person who ran that program with great distinction for a decade was our good friend Kurt, sitting here in the front row. And the importance of these determinations cannot be overstated. IARC determinations that a particular chemical causes human cancer shape cancer policy in countries around the world. I'm a pediatrician, so I always like to spend a moment talking about children as a vulnerable population. Children are very vulnerable to carcinogenic pollutants. Children can be exposed in the womb to chemicals that get into their mother's bodies and go right through across the placenta into the body of the baby. And then infants and children, once they're born, are at great risk because of their exposure patterns, because of their behaviors, because of their biological vulnerability, and not the least because they have 70 or 80 years ahead of them. And now we understand that a lot of chronic diseases like cancer are initiated, they're multi-stage processes that are initiated by exposures at the very beginning of life. And we now know from some long-term studies that children who are exposed to carcinogens at the very beginning of life are at higher risk, are at elevated risk for various cancers as they get older. We coined this phrase that children are not little adults. This is just a picture. This is United States looking at childhood cancer since we started keeping national records in 1973, 2 years after Richard Nixon launched the war on cancer. We started keeping national records, and childhood cancer is an interesting story. The good news is that mortality is going way down. I was a pediatric resident at Boston Children's from 1968 to 70. Any child who was admitted with a diagnosis of leukemia was going to die. Cancer was a death sentence just 50 years ago. Today, as you saw from Kurt's statistics, 88% of children with cancer in the Western world survive. But the bad news is the upper line there, that the incidence, the number of new cases of childhood cancer per 1,000 children, has been tending steadily upward. And in this past 50 years, that incidence has gone up by close to 40%. We don't know the reason why. It's too rapid to be genetic. It certainly cannot be ascribed to better diagnosis. It's got to be something in the environment or some combination of some things, but we don't really know what those causes are except for a few nibbles around the edges. So all that's the bad news, but there's also good news here. And the good news is that pollution and the diseases that pollution causes, including cancer, can be prevented. And what's the proof of that? The proof of that is that countries like ours, Western Europe, Japan, Australia, but also the rich countries, but also some middle-income countries, Chile, Mexico, Thailand, parts of China, have succeeded in controlling pollution. They've done it by putting together a package that's usually based in law and policy. Then they do enforcement, they have fines, they have incentives, there's a whole structure, and it knocks pollution down. And human health benefits as a consequence. Pollution-related disease and death go down. One very dramatic case study is the reduction in asbestos-related cancers. We still have way too much asbestos-related disease in our country, as Roger Flores will tell you, but it's not as bad as it used to be. And our Lancet Commission came to the conclusion that these measures, these policies, this toolbox, if you will, is ready to be taken to global scale to prevent cancer around the world, and human health, and also the economy and national security will be the beneficiaries. So what are the keys? Firstly, leadership matters. Political leadership at the city level, the state, the nation, even globally. Political leaders who stand up and do the right thing, who enact policies, who stand behind them, who are not corrupt, who don't take money under the table from polluters, are key to preventing pollution and its diseases. The will of societies matters. When the people in a country demand clean air, clean water, safe food, politicians listen. Then there are some specific measures: transition to public transport, targets and timetables, enforcement, getting rid of these damnable subsidies and tax breaks that we give to polluting industries. I was astounded to learn just a year or two ago, and I was delving into some of this stuff, that the fossil fuel industry in the United States gets at least $35 billion in subsidies and tax breaks from the federal government every year. It's actually probably more than that, because it's scattered around in different budgets, Department of the Interior, Energy Department, and elsewhere, but it's a huge thing. And then finally, most importantly, we've got to wean ourselves off of our addiction to fossil fuels and get into wind and get into solar energy and avoid the temptation to go for nuclear energy. And I think it's economically feasible to do that. I don't want to go into that in much detail today, but suffice it to say that the cost of producing solar energy from the sun has come down by 90% since 2010, in just a decade. The cost of producing energy from wind has come down by about 50% in that same time span. And in many parts of this country, it's actually cheaper today to produce electricity from wind and sun than it is from any fossil fuel, including gas. Pollution control can yield enormous economic benefits. So that lime green line that you see, this is a graph that you can see covers the years 1970, the passage of the Clean Air Act up to the near present. And in those 50 years, GDP, the gross domestic product of this country, grew by 250%. And at the same time, pollution, which is the gray line tending downward there, has come down by 70%. So anybody who tells you that controlling pollution and preventing disease is going to kill the economy and cost jobs is simply not telling the truth. Pollution control actually saves money. And the way it saves money is that it is twofold. First of all, it keeps people healthy, alive, and productive for many more years, so they continue to give back to the economy. And also it keeps people out of the hospital, so it reduces healthcare costs. Another example of pollution prevention is the classic story from the 1970s of how we got lead out of gasoline. Starting in 1975, when lead was ubiquitous in the American population, and we were using something like 1,000 tons of lead per year as a gasoline additive to increase engine performance. The average blood level in the population was around 20 micrograms per deciliter, which is a level that today would make an emergency room doctor's hair stand on end, but we thought it was the norm back then. In 75, as we began to realize that lead could cause damage to children even at low levels, EPA was persuaded to remove lead from gasoline. It was predicted that the average blood level in this country would come down a little bit, maybe by a microgram or two. In fact, this is what happened. It plummeted. The blood level fell by 50% in 5 years and has continued to fall since that time, with enormous benefits for society: 95% reduction in lead levels, in lead poisoning, an increase in the IQ of American children born since 1980. That increase in IQ translates to a huge increase in national wealth, because these smarter, more creative children, that's all of you guys who are our BC students, who can work computers the way that I can't, have returned billions to the American economy. And since 40 years have passed and 200 billion per year, do the math, that's $8 trillion have been returned to the American economy by the single action. So pollution prevention is possible. cancer prevention as possible, cleaning up the environment as possible, and all of those can yield great benefits. So the root source of it all, as Andrea has said more eloquently than I ever could, is short-term thinking. It's greed. It's focusing on GDP. It's viewing our planet and our people as expendable resources and exploiting them without a conscience. It's failure to link economic development to social justice. Pope Francis has termed this the throwaway culture. Think of one single-use plastic as a metaphor for the throwaway culture. And ultimately, this form of behavior is not sustainable. And that's why we're here today, is to talk about this nexus between the health of our planet, the health of ourselves, the health of our people, and social justice. So with that, I thank you.
Phil, thank you very, very much for that talk. Our next speaker is Raja Flores. Dr. Flores is the chair of the Department of Thoracic Surgery and the Steve and Ann Ames Professor in Thoracic Surgery at Mount Sinai Medical Center.
Oh, Raja!
So while they were doing that, I just wanted to say how thrilled I am to be here. I was raised by Jesuits, and I didn't realize Boston College was a Jesuit college for some reason. And from the time I was in grammar school as a poor kid growing up in New York City, the Jesuits provided a great education where, you know, our grammar school, it was optional. You could take $20 to enroll in this Jesuit grammar school. And sometimes we had the $20 a month to pay, and sometimes we didn't. But they provided free lunch and uniforms, and once in a while Yankee tickets. And I was an altar boy that I got to go to Xavier High School, which was a great Jesuit high school without tuition, and that sort of provided a foundation for going forward. So I'm indebted to the Jesuits for having raised me. And also my wife's uncle, who's a Jesuit, married us. So there's my kids are baptized, confirmed. So there's a lot of connection there with the Jesuits. So the talk that I am supposed to speak about is treatment and prevention. There's a balance there, and what dictates that balance? I want to see if you guys can guess what country this is. So this is the way they're sterilizing instruments for surgery. There's the betadine. This is an old-fashioned chest tube. This isn't the chest tube that we usually use. Once in a while, you can see some flies running around in where you're trying to sterilize the operating room equipment. This is the hospital. And I go to this hospital about once a year and perform surgery. Can you guess which country this is? Right? The cars probably give it away that this is Cuba. This is a patient that we've operated on, and you can see the little incision there. So you can go to a third world country and teach them how to do surgery using minimally invasive techniques. So here we have little incisions to treat this cancer patient. And this is the team here. And what you'll notice about this team is that they are very well educated on politics. They can talk to you about any little nuance in politics about Cuba. They can talk to you about politics in any other country in the world. They are extremely intelligent and very well read with regard to politics. Why? Because politics dictates whether they eat or not. Politics dictates every little area of their lives, and politics dictates medicine. And it also happens in the United States. Politics dictates whether we're going to spend money on treatment or whether we're going to spend money on prevention. And as many speakers have already talked about, Nixon's war on cancer back in the 70s, government, influence, and healthcare. And recently, Obama cancer moonshot, the Obama-Biden cancer moonshot. Why is it that government has to be involved in this, right? Because corporations release, these externalities that affect our environment, but government also dictates treatment and research and development and money allocated to treatment. How much money did we spend last year? Well, not last year, but the year before COVID. How much money did we spend on cancer drugs? Does anybody have any idea? On cancer drugs last year, we spent $150 billion. Just think about that number, $150 billion on cancer drugs. And what's even more appalling, 74% of those cancer drugs did not extend life, not by a single day. So we spent about $110 billion on drugs that didn't do anything. They did not extend life. And there are many different factors that dictate why we give more money to research and development and not to prevention. And it has to do with profit. Drugs are profitable. What would the drug companies pay if they had a drug that had a 30% cure rate, 50% cure rate, right? So we're watching the Super Bowl, and in the middle of the Super Bowl, you're seeing cancer drugs, which aren't even extending life. What they're doing is they're developing a response rate in the scans that you're getting. They're not getting rid of the cancer. They're not resulting in cures. But what are they doing? They're making money. And that's what we have to realize. There are many factors at play when it comes to balancing treatment and prevention. And screening is a unique area because screening is treatment. And like you saw, lung cancer is the most deadly cancer out there, and it's the cancer that I treat the most. And when we look at screening, of course, everyone jumps up and down. Well, we need evidence, of course, we're doctors and PhDs and, we're researchers, so we're intellectuals and we need the evidence. What's the definition of an intellectual? An intellectual is someone that takes something simple and makes it complicated. And so we need the evidence. This is the evidence here. We have these two big studies that we did. One is called the National Lung Cancer Screening Trial, and that cost $250 million. That is nothing compared to the $150 billion that we spend on drugs. And this actually results in a cure. So you look at this randomized controlled trial that was done, there's a 20% difference between the two arms, but how does that translate into actual patient care? Is that a cure rate? No, that's a difference that was set ahead of time. When we're trying to look at a cure rate, this is more likely. So if you are identified as having a cancer at an early stage, there's a 90% chance that you're going to be cured. That people can understand. This 20% difference, reduction in mortality between two groups, that's something that's a little difficult for people to comprehend. But this 90% will be cured. We get that. And like I said, this is for intellectuals because we need the data and we need to, play with it. But practically, this is a patient with the lung cancer. This is an X-ray. Where's the cancer? Heart's in the middle, right side, left side diaphragm, right? You can't see that cancer on there. But here you can see the cancer, that little dot up there. So it makes sense. You find the cancer early and you can get it out, right? We have a cure for cancer. It's called surgery. The only problem is we're not finding these things early enough. Yet we're spending $150 billion on drugs when if we just screen them, we would find them earlier when it's more curable. Right? This is what we used to find before we had CAT scan. You see the cancer over there on that left part of the screen? That's a big cancer. When you have a cancer that size, if it didn't go all over the body yet and it's still localized, what do you have to do? You make a big incision in their chest, you take out a rib, you put these big retractors in there to open things up, and you get out the cancer. Nowadays, we make 3 little holes. If you find it early, 3 little tiny holes. There's the nodule, 1 stapler that way, 1 stapler that way, bada bing, it's out. We can let medical students do this. This is so simple. But we just have to find it early to be able to do that. I mean, if you don't believe me, it's out in the movies. Here's A Bronx Tale, which is about a mafioso giving advice to a kid growing up in the neighborhood. Trouble is like cancer. You got to get it early. If you don't get it early, it gets too big. Then it kills you. That's why you got to cut it out. I mean, a mafioso can understand this. Yet we're over here playing around with numbers and weighing everything like the good intellectuals that we are. This is simple. Yet screening gets so little in the way of money. And yet you're treating, so it's profitable. Imagine trying to push prevention. What kind of obstacles we will find when we push prevention. So when we talk about prevention, smoking, right? How many years passed, 50 years, where they were trying to prove that smoking was actually good for you when doctors were advertising it. And why are we seeing this decrease in lung cancer mortality? Because less people are smoking, at least in the United States. So it's a decrease in the carcinogen that's out there. And who's not happy about it? The people who profited from it, the tobacco companies, Philip Morris. Marijuana, that's the next thing. You're going to start seeing people with cancers from marijuana because I've seen it in my clinic. And what I've also seen is the way it's being marketed. There was a health magazine the other day that I saw where a fit young woman with a ponytail was running, and it said marijuana, organic, natural. And it made you realize, wow, they want to not only market it to you, but make you think that it's good for you. And I prescribe marijuana for my cancer patients, but they're using medical marijuana as a Trojan horse for recreational marijuana. And I don't think any of us want our children doing recreational marijuana. But this is where it's going. The other thing that we see harming our kids, vaping. Why? Because it makes money, right? It's easy to prevent these cancers and illnesses by preventing these products. But that's another fight. Asbestos. So when we talk about asbestos, and if you identify asbestos in a building, the property value of that building goes down. It costs a lot of money to abate it. So they'd rather not talk about asbestos and not prevent and not protect people from asbestos exposure. I'm curious, everybody here, when was asbestos banned in the United States? Show of hands, 1960, 1975, 2000, 2015. So it's a trick question. Asbestos is not banned in the United States. And many times people will be surprised when they hear that. But the property owners don't want to be liable. When they are doing construction, many times they just, oh, could that be asbestos? They just want to ignore it. When the towers came down, ton of asbestos in there, right? And this is causing cancer. I mean, it's very easy with mesothelioma. You get rid of the asbestos, you won't get mesothelioma. But it actually causes lung cancer as well in a greater number. And when you look at the healthcare costs in the United States, 18% of our GDP is spent on healthcare, $3.3 trillion. And that has to do with drugs, that has to do with technology, it has to do with a lot of things that are not necessarily translating into better health. All right, let's look at technology, for example. The robot. Everybody's heard about this robot. And when you look at this, Is this an educational seminar to teach people? You've got MD Anderson, you've got Sloan Kettering, where I was for 10 years before I came to Sinai, Moffitt, Mayo Clinic. Right? So is this an advertisement or is this an educational series? I tell you, this is marketing. This is Da Vinci figuring out how to ride on the coattails of these cancer centers to promote a product that they have. Next thing you know, in the New York Times, we want doctors and patients to be aware of the lack of evidence of safety and effectiveness for cancer treatment and care. So the FDA is washing their hands of it. They don't want to be responsible when you start getting hurt because of a robot. And it's not like I haven't used the robot. I've published many papers on it. I was probably one of the first groups to start using the robot. So it's not like I'm a naysayer. I've actually researched this. And in the end, what I find out is that robotics, the technology of robotics, is not guided by patient outcome. It could be by academic recognition. You know, when you're starting out as a young surgeon, you want a little niche so that you stand apart from everybody else. So this could be that. Is it money? Is it marketing? What is driving the robotic push in modern medicine today? $62 billion company, Intuitive. You think that has something to do with it? They can put together educational series. They can put together a lot of things. There's one person who they fly around the entire country on a private jet. So they're using marketing to promote a product that gives them profit without resulting in improved care for patients. And then when we look at where all our healthcare dollars are going, this is a big part of it. So what does the robot add? Time and money, not safety. I actually have found a good role for the robot. This is my operating room at Mount Sinai. And this is, I think, a well worth investment for a coat rack. So that's where I keep my coat. I can go to a third world country and show them how to do this surgery with little holes. You don't need the robot to do that. And that's the point. But what's affecting us now more than anything else? COVID, right? And as opposed to looking globally, I want you to think about what's happening in our own backyard. This is a patient with COVID. This is that same patient better without COVID. This is Mount Sinai. This is Central Park. We had tents. My office is up in that big building looking out onto this thing here. And in March of last year, the hospital was full. The lobby was full of stretchers. We had colleagues that died. I had family members that died. And what's interesting is that you see the differences in susceptibility based on where people lived. Now, see, Mount Sinai, there's two sides to Mount Sinai. It's located in East Harlem, in between the richest of the rich. This is St. Bernard's, which looks out on 98th Street at Mount Sinai, one of the most prestigious boys' schools in New York City. And this is on the other side of Mount Sinai, the Carver housing projects. And many people who live in the Carver housing projects and in the public housing in East Harlem actually work at Mount Sinai. Mount Sinai is the #1 employer of people in East Harlem. And who lives in these public housings? Secretaries, janitors, nurses, transporters. Many times I'm staring out of the window as I'm waiting for my case to start. I see people coming right out of Carver and walking right into Mount Sinai. Who are these people? They are the essential workers. When COVID hit, they were the ones who kept coming to work. They were the ones who kept the hospital going, drawing blood, transporting patients, nurses, nursing attendants. So they are the backbone of our city, of our country when it was hitting the fan. And I don't think many people understand that. There's a false narrative with regard to people who live in public housing, that they don't care, that they do this to themselves. And that's not the case. And I'll talk about it a little more here. But this is where they live. You got paint peeling, which probably has lead in it. You have appliances that don't work. You have flooding that leads to mold. And you can see the mold on top of the bathroom ceiling here. This is where our essential workers are living. And what happens? They can get mold, not just talking about cancer from asbestos, but mold from the fungus there. And what happens? Then we got to go to the OR and take it out. And sometimes we have to put a hole in their chest to get rid of it for something that is preventable. So it's not only predisposing them to fungus, to unnecessary surgery, but to cancers as well. There are 3 short studies that I'd like to talk about, one done by tenants, one done by the Housing Authority, and one done by New York State. So the one done by tenants looks at Rockaway. Rockaway is a place in Queens, and it's a peninsula. You got Far Rockaway, and then you have the non-public housing part of Rockaway. And what's interesting, they surveyed 700 tenants, and they found 6 times greater rate of death in the Far Rockaway or the public housing Rockaway compared to the other Rockaway. 6 times. Then NYCHA looked from the mold standpoint. This is a different study, and they found that to fix mold in public housing is $10 billion, right? Where's that money going to come from? Because it's not just fix the ceiling. There's structural problems. There's collection of mold, of water on the rooftops. Nothing's being drained. But the saddest study that I saw was conducted by New York State that came out 3 years ago. And they found that 83% of public housing apartments in New York City had a severe health hazard, which included mold, asbestos, lead, rodents, and 2nd and 3rd degree smoke. The diseases that you get in addition to cancer are there, and all these diseases predispose you to dying from COVID. So they were disproportionately affected by COVID. And what do? They blame the victim, right? They say all these people are on welfare. New York City public housing, 13% are on welfare. The general population of the United States, 20%. They have this false narrative about people who live in public housing because then they can ignore them. They did it to yourself, but they pay rent. And they were the ones who were there fighting when COVID hit. And the state, after they did this study, gave $0 to public housing. Why? Because they don't vote. They're too busy working and trying to survive. They're not even thinking about voting. And the politicians know that. And so they just neglect them. So to summarize, the difference between treatment and prevention is money. Prevention is not profitable, but it's the right thing to do. And I think we have to understand the money influences, especially when it comes to drugs, and that how big pharma influences politicians' decisions as far as allocating research dollars to certain areas, because big pharma is on a lot of these boards. And they will influence the NCI. It's like the tail that wags the dog. They will influence the NCI into giving research dollars to corporations and big pharma because that is profitable. And we need to focus on simple things that actually can prevent disease rather than treat disease after the fact. Thank you for having me.
Thank you very much. Thank you very much, Dr. Flores, for that very compelling talk. Our next speaker is Lillian Ferrara Lagunas. She is the Vice President for International Affairs of Pontificia Universidad Católica, how do you say it in Spanish? Católica de Chile. She has a Master of Science in Nursing and a doctorate in Public Health from the University of Illinois at Chicago. And she's a tenured professor at the School of Nursing. And she is going to come to us on Zoom.
Yes, good afternoon, and thank you so much for the invitation. I would like to share my screen, but I'm not allowed to do so.
You can share your screen. No?
No, it says there that the function is not working for me. So, well, as I said, thank you so much for this invitation. Greetings from Santiago, Chile. I hope that you are having a good time in Boston. And I have been very, very impressed by the previous presentations, and I would like to talk from the perspective of a healthcare professional working in Latin America, in a country that it's considered a high-income country, but it has a lot of problems with inequities and difficulties in terms of providing the care that people
Lillian,
need.
Lillian,
Yes.
sorry. You should be able to share now. Sorry to interrupt.
No, it's fine.
Thank you.
Yes. Now it is.
Did the sharing work? We cannot see you, Lillian.
Can you hear me now?
Yes.
Yes. And can
Here-
you see the presentation that I'm sharing?
We see you, but not the presentation.
Okay, let me try one more time. If not, I can
Thank you.
just skip the PowerPoint. Is it okay now?
We see a black screen. Screen start. Okay, now we see the presentation.
Now you see the presentation, great. Thank you. So as I was saying, thank you so much for the invitation. And I would like to share my perspectives from a Latin American country, a country that it's considered, as I said before, a high income country, but that has a lot of issues in terms of the distribution of the resources. Of course, given the context of being a Latin American country where we are encountering new social issues and problems that in the United States you had decades ago, like, for example, immigration. Globalization allows us today to be more connected and have a better access to information among different countries. By this, problems around the world are known, and comparisons between different cultures, communities, populations, and communities are inevitable. Focusing solely on the people, we can see that each one has personal resources available, but at the same time, their environment in which they live will determine the level of health and risk factors and daily habits, and those are social determinants of health. Culture nowadays is a strong determinant of the health of the population, and there are diseases that are transversal to it, such as cancer. Today, cancer is one of the leading causes of death worldwide, and it has been presented this morning. And when considering the population growth rate, new sedentary lifestyles and aging are increasing of approximately 60% in the number of cases is projected, and being estimated up to 81% only in the middle and low income countries by the year 2040. Aging is a great challenge given that oncological problems occur more frequently in older people, and that there is a change in the form of treatment because chemotherapy and radiotherapy are being preferentially performed through ambulatory care, which allows reducing the costs associated with hospitalization. However, this requires different models of care, and particularly considering non-medical teams a lot of the times for the management of side effects at home, which ultimately result in a constant technological advance in care or interventions. These aspects unveil global and local differences between communities, given that populations in situations of vulnerability present lower quality of life, which will translate into aging in unfavorable conditions. If we add that the conditions of the home do not have basic services or are exposed to pollutants, it will be more difficult for them to recover from their health condition in an ambulatory way. In relation to technological advances, even if they are available, not all people will have access to them in a fair way because they are not available in their country or have a high cost, among other reasons. The above scenarios show us that inequities have serious consequences, even more so if we consider access to health as a right for all people in the world. This means that all people, despite their genetics and lifestyle, may have the possibility of accessing interventions for promotion, prevention, rehabilitation, diagnosis, and/or treatment. Health as a social right means that everyone should receive care according to their needs. The ethic of public health is to protect and provide coverage to the essential collective needs of people. It also adds the fundamental ethical principles, including protection, which ensures welfare, meaning that the state must respond to unpostponable needs. Justice considers equity in the application of policies, strategies, and actions, which emphasize on the most vulnerable to avoid discrimination and unequal distribution of opportunities. Reciprocity, considered as compensation for damages through a balance between benefits and burdens. For example, creating support measures for communities facing a situation of lower health protection and accountability, being able to answer for the consequences of decisions. Here, as St. Paul John II said, the ethical relevance of the good of health is such as to motivate a strong commitment to its protection and treatment by society itself. It is a duty of solidarity that excludes no one, not even those responsible for the loss of their own health. We shouldn't be blaming the people who are suffering. The ontological dignity of the person is in fact superior. It transcends his or her erroneous or sinful forms of behavior. Treating disease and doing one's best to prevent it are ongoing tasks for the individual and for society, precisely as a tribute to the dignity of the person and the importance of the good of health. I think that we have been touching bases with how we should encounter, for example, people not following the suggested behaviors or not following suggested treatments. But I think that the most important thing, and particularly considering healthcare professionals, we should focus in really caring for the good of the health of everybody, regardless of their own behaviors. There is an unequal distribution of opportunities. There are countries also where medical care is scarce, or within the same nation, urbanized areas concentrate the greatest supply of health services and benefits compared to more rural areas. Besides, we sometimes don't even consider, for example, traditional healers or traditional healthcare beliefs that are really associated with how people are going to behave. This generates differences that have a negative impact on health due only to where you live in the same country sometimes. This slide contrasted with the characteristics of the communities. Culture is a significant factor when it comes to implementing care or proposing new behaviors. Since cultural factors are immersed in life habits and personal beliefs, for example, environmental management, where it is considered in a more global way, aimed at pollution, or at the local level, Or sometimes, what are the resources available for keeping a heating system inside your house? Those things, particularly in Latin America, are very, very critical. If you have the resources available, if you don't have them available, and if they are available to their communities, have indirect cultural implications on health management. For example, Thomas Pu and Diaz point out that biological, genetic, and environmental factors report differences in risk, incidence, diagnosis, treatment, survival, and mortality in people with breast cancer. Other factors are aging, urbanization, and fertility. In relation to urbanization, we can see that the incidence rate of breast cancer is higher in urban areas, which is explained by a higher detection of cases. Urbanization leads to less healthy habits and less physical activities, and together with poverty, it is identified as a socio-demographic determinant of breast cancer incidence. In Colombia, oral cancer has a higher risk incidence in the older adult population, in urban areas, and in situations of poverty or vulnerability. They also highlight possible barriers of access to health services, which prevents timely diagnosis and treatment, hence frequently finding the pathology in more advanced stages. In Chile, for example, cancer is included in the program called Explicit Warranties in Health, which assures access, opportunity, financial protection, and quality for certain types of cancer. However, this program has another issue. It has a curative approach and focuses on the pathology and a biomedical model, not prevention, not trying to find the disease in an early stage. We only follow the idea of treating it when it's present. And unfortunately, and nowadays during COVID times, it is expected that in 7 more years, we're going to have a terrible increase in deaths due to not identifying and doing an early diagnosis for cancer. Social responsibility in the face of this health problem has driven international research allowing cultural cross comparisons. For example, the care for a pathology considering the culture of the people, giving that an understanding of the context is required for research, care, and advances to have a great impact on the population. By being a member of a society, there is a mutual obligation to have moral relationships between different people from all parts of the world. In addition, there are connected institutions and practices that are mutually influencing each other by performing actions, by having obligations of justice that arise between people by virtue of social processes. The social connectedness model points out that all agents contribute to the structural processes they produce. This means that even if one lives in an area with all the resources and services, including health, one must still contribute to social equality. Within this responsibility, we consider innovation as a resource to contribute. Innovation is defined as a process of inventing, creating, securing support for, and implementing novel solutions to social needs and problems. It is known that usually the healthcare models are very paternalistic, and we don't want to get out of the comfort zone. This, when applied to healthcare, as I said, is to be able to ensure that treatments and care should be available to all people, including the most vulnerable and hard to reach populations. So why are there differences in the course of diseases? PAHO, the Pan American Health Organization, describes that the state of health of the population is linked to the socioeconomic situation, the cultural context, and the values in which society is installed with its governmental and private actions. Knowing the impact of socio-demographic factors and their environment, it is proposed to have a preventive care model to be able to reduce the incidence and detect cancer in early stages, having a better prognosis of life for the person. Generating innovations is fundamental for the health system because it will contribute to great sustainability and a diffusion of the impact to the different communities in the world. But I insist we need to get out of the comfort zone. And usually, historically, in healthcare settings, we feel more comfortable staying with what we have been doing always. When we consider innovation in cancer, we can refer to the initiative promoted by Basel to have advanced practice nursing, for example, in Latin America. It is essential to promote interdisciplinary work teams to consider all aspects of people's lives and thus create care that is adapted to their particular reality. On the other hand, there are efforts to create more inclusive models of care that reach more of population. For example, in Chile, advanced practice nursing with a mention in oncology was promoted to reduce problems of access and coverage by being a professional with the ability to diagnose, treat, and follow up, but mainly because we have a more integral, holistic view of conditions in health. This would help to reduce the current gap in oncology specialists, but also it will make models to treat patients with cancer more closer and more culturally competent. Working complementarily with a consolidated oncology medical team, nurses would expand care opportunities for patients. In Chile, this profession has been incorporated in the National Cancer Plan and in the National Cancer Law. And especially today, I would like to thank Boston College, the School of Nursing, because thanks to you, we have been able to create the first nurse practitioner program in the country. And actually, it is the first nurse practitioner oncology cancer program in Latin America. So thank you so much, because Boston College was the school that formed the first 2 nurse practitioners that arrived to Chile and are now really pushing for this initiative to grow. In today's globalized world, in which diseases that affect poorer or less developed countries can affect the entire planet, we must care about the health of the most vulnerable as a matter of social justice and care for our home, our common home. Interesting in the perspective of Berwick, who proposes that the major investment should be in correcting the social determinants of health and not in continuing to build and provide care in large, expensive repair workshops that do not address the cause of the problem, and in a low investment in health promotion that fails to change human well-being. Thus, he proposes to base the motivation to change human well-being in health of what he calls the moral determinants of health, among which the most important is a strong sense of social solidarity, in which people understand that they depend on each other to ensure the health of all. And I would like again to mention Boston College and particularly the School of Nursing, because they actually has invested in trying to support the cancer care related or the care of patients with cancer in Chile and several or thousands of miles away. In summary, the globalization has allowed us to have a great connection between countries and communities, which has allowed us to know the impact that some diseases have around the world, such as cancer. And at the same time, this has generated international collaboration through research, being able to know different realities, differentiating people according to their culture. However, as there are differences, we can see that not only people have the same access to healthcare at any level, violating fundamental values. By having a social responsibility in the face of these disparities, we hope to continue contributing through innovation to better healthcare and the reduction of gaps in access and coverage. Among the countries following this line of action is Chile, with an advanced nurse practitioner initiative. It is expected that models of care will be created And with this idea of prevention and intercultural approaches, while considering social cultural factors, this motivation is aligned with the words of Pope Francis. It is impossible to the local in a healthy way without being sincerely open to the universal, without feeling challenged by what is happening in other places, without openness to enrichment by other cultures, and without solidarity and concern for the tragedies affecting other peoples. Thank you so much for this initiative. And again, I give thanks to Boston College, particularly the School of Nursing, for the contribution that you have been doing for the care of people with cancer in Chile. Thank you very much.
The final results, 4 years later, 6 years later, you get hit with reality. We're making progress, but we're not even close to the magic bullet. And I think, I've been seeing it for the past 20 years where, gemcitabine, cisplatin, oh my God, this is it. Okay, it's not. All right, pemetrexed, cisplatin, okay, no, it's not. EGFR, that did something. Of course, now the PD-L1 inhibitors, all of that. But when you look at this study that just came out, it showed that 13%, which means, 87% still aren't getting what they should be getting. So I think there's progress, but we're not there yet.
Wait a second, please.
Thank you for excellent presentations, all three speakers. Also following up on Raja and what you just mentioned, I think with this new personalized medicine, we always also have to keep in mind that most often, even in the high income countries, this is further increasing the social inequalities because it's only a few that really get that latest treatment. And again, the treatment kind of improvement for some cancers, there were a real breakthrough like melanoma, etc. But altogether for the most frequent cancers like lung cancer, the progress is not very strong. Now, you rightly pointed out the kind of a screening and that there is now evidence, and I would agree that screening for lung cancer with low-dose spiral CT is effective. However, we also need to keep in mind, again, this may increase the social inequalities, particularly in the US where we don't have organized screening programs. It's opportunistic screening programs. And the evidence on this lung cancer screening is really on a highly restricted, high-risk group of heavy smokers at a certain age. Now, at the same time, lung cancer screening is aggressively advertised across the US to all, say, to grandfathers. You make sure that you stay a grandfather to your child, to the children, etc. So I think there is also a dimension of profit in lung cancer screening, and that I just wanted to add to the point, to the excellent points that you made.
No, I think that is a good point. You know, with every treatment, every intervention, it can be a double-edged sword. And there are people out there that try to benefit and profit from every situation. So just like, you know, you want to make sure the drugs are given to patients who really will benefit it, or screen the population that will best benefit from it. You also have to realize that the people in charge of administering these therapies are humans. So what I tell people who are getting screened for lung cancer, you don't want to go to a surgeon with a quick trigger finger. You want to make sure that the surgeon doesn't see something right away, wants to cut it out. They've got to be able to watch it and see exactly the natural biology of this. But there's also the component with regards to screening of boy, I'm getting old. I can't remember now. I lost my train of thought, but well, go ahead. I'll remember it in a second.
Thank you. I'm Cesar Lopez. Feel a little inadequate. I'm a master's in business administration among a doctorate, so I hope my question is appropriate. But I really want to thank Dr. Landrigan and Dr. Flores, and certainly everybody that's presented here. But most poignantly, gentlemen, you hit the theme of, you know, there's been 250,000 chemicals introduced. There's, you know, the technology that's being marketed. And so there's definitely a tremendous amount of business and not enough necessarily done to curtail what causes the disease. And so I'm wondering if there's frustration among the academics or those that are seeking to act, because, you know, certainly Dr. Flores, you know, you also highlighted your trip to Cuba, you're running as a representative. And so do you feel that there's enough pressure on the political forces, the business forces that can support academia or those that perceive the problem? And if not, what areas do you think can be addressed? And one of the things I think of, and Dr. Landrigan, I highlighted your chemicals. So for instance, when you get an FDA drug approval, right, there's a tremendous amount of testing that has to be done prior to that drug being rolled out. I'm certain that for the 250,000 chemicals, there's not that amount of testing that has to be rigorously done before they're introduced to industry. And so it's a post-evaluative analysis. And so I'm curious to hear your commentary on those topics.
So I also remember what I was going to say before, and it touches on what you brought up. Basically, talking about the screening population, the smoking population. What's interesting is that there was a big political battle in the lung cancer screening academic literature, where there was a fight between academics of whether screening was the best thing or whether screening caused harm. And there was a lot of outside influence. So exactly what you said, there's a select group that was screened. What's interesting, though, is that's not the highest risk group for lung cancer. Asbestos. Asbestos gives you a higher risk of getting lung cancer than even smoking. Yet they are not allowing us to screen patients and get and be able to pay for it through Medicaid if they just have asbestos exposure. So there's so many angles, and you just don't know what angle is in the best interest of the patient and what angle is just in the interest of profit. And the whole thing has had me so jaded in medicine where I just can't sit back anymore. And I feel like I got to rage against this machine that's out there. But, you know, so that's an example of asbestos is not even considered when we know you're at more of a risk of developing lung cancer with asbestos exposure than smoking. But go ahead, Phil.
It was a great question.
Just a quick.
It's a great question, and there's not much I can add to what Ora just said. I don't have the passion. All right, I do, but I express it in a different way. Let me commend to you a fantastic book. It's not new. It goes back at least 40 years. It's called The Politics of Cancer, could just as well be called The Ethics or the Moral Theology of Cancer. It's written by a pathologist in Chicago, now deceased, Samuel Epstein. And Sam Epstein talked, the parable he told was the story of a man named Armand Hammer. So Armand Hammer was a physician in the first half of the 20th century, came to prominence. Brilliant doctor by all accounts. Also a very shrewd businessman who was the founder of a company called Occidental Petroleum, which became OxyChem. They produced lots and lots of really, really terrible chemicals, proven human carcinogens. But he also had a very profitable business selling cancer chemotherapeutic agents. So basically, he was getting people coming and going, right? He was unethically, as a physician, marketing chemicals that were known to cause cancer, and at the same time selling people the drugs that cure the disease. It really not the way to behave. That's the sort of immorality, lack of concern for the other person, lack of concern for common humanity that we're talking about here today.
He sounds like a hedge funder.
Please join me in thanking our speakers, and we are grateful for your contributions.
Yeah. Which one is it? Is that this one? I can take this one out, maybe. Can we take this one out?
Excuse me.
Can we take this USB out?
Can I just stick my computer on? It's a problem because this is connected to Zoom. If you don't have this, we cannot show anything.
Oh, there it is.
Where it is?
Most recent. Just to date.
Do you wanna? That one? Okay. And then I'll put it up. Thank you. Sure. Yeah, of course. And then, there we go.
Kathy, when you want to begin?
I'll stand, I think. Hi, Kathy Caveney. Good morning, a beautiful fall morning in Boston, and I hope wherever you are virtually. I'm Kathleen Caveney, and I am moderating this panel on legal and political protections. And the reason it's important to talk about legal and political protections is because we are working at the intersection of medicine and justice, and both those topics are heavily regulated. So all of our ethical insights will need to be somehow translated into law and policy. And today's panel will help us do just that. A full biography is available in the program for the conference. So just a quick reminder about our three speakers, because you want to hear from them rather than me. Our first speaker is Professor Richard Jackson, Professor Emeritus at the Fielding School of Public Health at the University of California, Los Angeles. For 9 years, he was the director of the CDC's National Center for Environmental Health and received the Presidential Distinguished Service Award. Our second speaker will be my colleague at Boston College Law School, David A. Worth, who is a professor of law here, where he served as director of international programs. He teaches primarily in the field of public international law, with a particular research interest in international environmental law, an area where he worked and practices for more than 2 decades. And our final speaker is Nezdu Obat Witherspoon. And I'm sorry if I mispronounced your name, and please correct me when you get to the podium, who is the Executive Director of Children's Environmental Health Network, where her responsibilities included successfully organizing, leading, and managing public policy, education, training, and science-related programs. For the past 18 years, she has served as a key spokesperson for children's vulnerabilities and the need for their protections. So we will have a first part of the panel, 3 speakers, each speaking 20 minutes each. And then if we do it right, we will have time for 20 minutes of questions. So let's start with our first speaker, Professor Jackson.
Well, I've been a little guilty because I came with one set of slides, and as I listened to one marvelous lecture after another, take that one out, take that one out, add this one, and so I had to change it over time. I come from the San Francisco Bay Area. We live in Berkeley, and a year ago, we had a Martian day where it was really totally frightening. This was noon over the Bay Bridge on September 9th. The state has been on fire for the last 2 years, except for the dead of winter. And on this particular day, the fires were so huge, they were blowing out over the Pacific up to about 5,000 feet and then blowing back in. So the ground level was pretty good, but above us, this whole world was turning red. Even the dog was freaked out. And a norm, I had to laugh the other day. The New York Times had, after the floods, the second once in a century flood in New York City in 1 month. After that, they carried an article on how to have a go bag and what should be in your go bag at your house. Well, this is normal and everywhere in California. We all have it. Realized after a while you have a bear spray. Some people think they have to have guns, but it's the way it is. So I'm going to think about 5 words that, 3 of them that over-direct humanity and maybe 2 that are in the range of it's fine, I'll just do this. Jesus said, many are cold, but a few are frozen. So this next picture is when I started in 1994 at the Centers for Disease Control and Prevention. My boss was David Satcher, and over time, I had come out of a deep immersion in public health and housing and pesticides and other such issues, and realized I had a real ally in Dr. Satcher. And I learned a number of things about him. He had grown up in Anniston, Alabama, one of about 10 children. When he was 5, he went on to get an MD and then a PhD and was eventually appointed head of CDC and appointed Surgeon General to the United States. When he was about 4 years old, he developed whooping cough. And anti-vaccine people have no idea what a nightmare it is to have whooping cough, but to be with a child with whooping cough. And for 5 minutes at a time, the child will be gasping for air, turn blue, sometimes vomit and pass out. And his mother, David Satcher's mother, brought him to the Anniston, Alabama hospital, but because he was a Black child, they would not admit him. And he spent the next 9 days in hour by hour, minute by minute care of his mother. And so the commitment to people who are disenfranchised and disempowered was so strong for him. And he was a great supporter, not only in genetics and public health, but also on around issues of the border and border health and issues of asthma. One of the things I learned, and I once was on an AM radio show where the guy was really in my face and he said, oh, you know, you work for Schwarzenegger, you're the state health officer, you work for government, you must be either corrupt, stupid, or lazy. That's the kind of greeting you get on AM radio. And I'm not corrupt. I try my best to be honest. I don't tell everybody everything because that's a bad way for people to be. I'm not lazy. I work hard, but I feel ignorant all the time because every doctor is at the edge of his or her knowledge constantly. And the worst doctor and the one to stay away from is the one that thinks they know all the answers. You want to be around one that knows who to call when the time comes. And I said, sir, the purpose of public health is not to run the nanny state, because he was in my face about seatbelts and smoking and vaccines. And I said, well, it's not to run the nanny state, it's to assure conditions where people can be healthy. And yes, if I want you to be healthy, I want to be healthy, I don't want to be in an airplane next to a bunch of smokers. I don't want to have people driving without seatbelts with their children in the car. And it's a somewhat more evasive but genuine look into this. I had never met Dr. Flores before, and I'm going to introduce him to Jane Brody and a bunch of people because I think he needs to be the next Surgeon General at the rate he's going, because I think he really captures so much of these issues. But I was state health officer for California, and early on, I thought that all of the most important word in California was water. You know, we're pretty much out of water on the Colorado River, and the Delta's drying up, and the Sierra doesn't have much snow on it anymore. And that's a 5-letter word. We spend 20% of all the electricity in California to push water around, believe it or not. And yet our fields, our orchards are drying up in the Central Valley. And but then I realized, well, that's a 5-letter word, but really water is the same as power in my state, another 5-letter word. And so much of what goes on is because people want power. And I'll come to that last word very shortly. So money. Hey, the more money you spend on medical care, the longer you live, sort of. So you can see this is international description of how much each country spends on medical care per capita. You see Japan is the highest span of life at about, but they spend $4,300. But I have left a country off this graph, OECD graph. Slightly old data, but here's the US at living to be 77, 78 years old and spending now, it is well over $10,000 per head. So this mismatch that Dr. Flores was talking about between what we spend and what we get is a bad bargain for any businessman from the business school, as the gentleman was pointing out. And numbers are slightly old, but we're still at about 17% of every penny in America. I've been obsessed recently for a long time about climate change. We spend 17% of all the money in America goes to the medical industrial complex. 10% of all the carbon footprint of America comes from the medical industrial complex. You know, everywhere you walk, you see discarded masks and other kinds of activity or other things. But think about the waste. The quantity of waste it's from each patient in the hospital and from overall is huge. So for a long time, life expectancy improved in the United States. And between 1900 and the year 2000, the average American's lifespan increased by 30 years. How much of that came from medical interventions that we spend all this money on? 5 years. The other 25 have come from the things that Dr. Landrigan and Kurt are talking about. It's really about public health interventions, the big one being immunization, to a lesser extent antibiotics, which are kind of a public health intervention as well. And the other big one is changes in the physical environment, that clean water, clean food, clean air, cleaner workplaces that Dr. Landrigan has spent his life working on. And so we've begun to flatten out in terms of our improvement of our lifespans. Well, as Dr. Flores mentioned, we invest a lot in research. And I worked at CDC overall about 15 years. NIH has a budget about 3 times of that. By the way, CDC and NIH's budget combined is still less than the Department of Defense's overall computer budget. So you realize how minuscule public health is compared to the defense enterprise in the United States. But NCI, National Cancer Institute, is at about $27 billion over the last 5 years. So we clearly must be doing much better on cancer, having spent that colossal amount of money. Well, here's the latest age-adjusted data for deaths in America. And you're not surprised to see COVID-19 now the #3 cause of death. It even exceeds firearm deaths in the United States and traffic deaths, which is not good news, but it's quite a adjustment to the causes of death. But cancer is #2 at about 700,000 deaths a year. Cancer rates are declining more in countries that if you consider developing countries, dropped over time more than the US, but they're slowly going down. And but one of the things, and the last word was greed, and the thesis I'm going to make here is poverty is not good for you. And we have a powerful production sector and a fiscal sector. I mean, it's absurd what is going on in the stock market. It's probably twice what it was 2.5 years ago. So huge amounts of money are being generated, and that's a good thing, right? But poverty is not good. The richer you are, the longer you live. So you divide up the US population, the top quintile, the richest 20% lives considerably longer than the next one, then the next one, the next one, and the poorest 20% are down at about 50th ranking for lifespans. Well, this had to be, it's just America, this is always going to be. Well, no, here's some history that's worth looking at. Paper from colleagues, one from Fiesole and some from other universities. From the end of World War II to the end of Jimmy Carter's administration, this was the change in household incomes over that generation. So in general, household incomes for the top 20% and the bottom 20% all doubled. I would have liked to have seen the bottom 20% go up more, but at least it was even. Everybody, as Kennedy said, the rising tide has lifted all boats, about twice the real income. In 1980, a president was elected that said, government is bad for you, and I'm going to I have to reduce government. And one of the ways to reduce government is to reduce taxes and other sorts of things. So here's what happened for the next 22 years is the bottom 4 quintiles went up about 10-15%, and the top 5% went up 68% in their income. And this was, if you look back at what was going on taxes, they were just being lowered and lowered. But this shows real income. What do you think happened with after-tax income? So the top quintile is now making twice as much as they were at the beginning of 1980 in real dollars. And look how that compares with everyone else. So what happened to wealth during that time? Well, back in 1970, if I had walked up to someone and said, well, the top 1% of people, how much of all the US wealth would they have? They'd say, I don't know, maybe a third. And how about the bottom 10%? What would they have? Yeah, well, about a third. Well, that's what it was. How do you think that changed? And this is a health issue after all is said and done. By 2014, the top 1% had 2/3 of all the wealth in the United States. And I grew up poor. My dad died of polio when I was 3, and my mom had 3 little boys. And being poor is tough. You're worried about what to eat, and the car breaks down, and how do you get medical care, and the dentist is expensive. It's a very difficult situation to be in. The bottom 90% had only 10% of the wealth. The top 10%, 1% has 2/3, and the bottom 90% has 10% of all the wealth in the United States. And this is income, so it's a little different from wealth. But look what's happened. The blue line is the bottom 90%, and our share of the wealth has dropped. And at this point, the top 0.1% has more wealth than the bottom 90%. These are dramatic shifts in just our short time on Earth and my children's lives. And at this point, the top tier is the top 400 families in wealthy United States are paying less in taxes every year than you are. You see Tiger Woods' new yacht down there in Florida is $250 million, and his ex-wife has one next to it that's slightly more expensive. But you know, why do people need that stuff when people are dying literally for what they need? Well, where's all this wealth going? Well, Dr. Flores reflected on this. I live in Berkeley. Sutter chain took over Alta Bates Hospital, a very good local hospital. Pretty soon the number of nurses was dropping, and then the COVID hit, and they continued to lay off nurses. They increased the amount of care that the nurses were required to give, even in the intensive care units, 4, 5, 6, to the point that, and then did not supply adequate PPE to the nurses in our hospital. And it was an outrage, and union lawsuits, the whole thing. The guy running Sutter was, and the MBA running Sutter was making $18 million a year as they were doing this to the people giving the actual care. So you can see the transfer of wealth that's been going on to the people running medical care systems and also pharmaceutical industry people. And this sort of closes the loop on what Dr. Flores was saying. You know this one, but the wealth gap between white, black, and Hispanic in the United States is striking. 1 minute. Oh, stop. Oh, all right, real fast, because this isn't. All right. If you have a legacy and inheritance, one of the problems with Tulsa was that it destroyed the legacy and inheritance for African-American population on the Wall Street of the United States. Redlining has completely destroyed 100 years worth of wealth of the African-American population because the homes that they had in the red line districts where people wouldn't buy did not increase in wealth, and a lot of reasons between what they could get as heirs did not occur as well. But one of the things that was astounding to that study, that looking at redlining, is even 90 years later, the areas that were redlined were not only still much poorer, they were much hotter because the folks living there could not afford the landscaping, the trees, the cooling cover. And so city by city, we've seen redlining areas being much more at risk from heat waves and heat damage as well. So this issue of how money begins to, and inheritance and being marginalized for getting the access to the resources that you need to live has increased over time. Thank you very much, and I will stop at that point. Oh, I got 1 minute there. Do I have a couple more minutes? Let me see what I can do to wrap up. Oh, I have to tell you this slide. So our worst, obesity is the big, average Americans gained about 25 pounds in the last 25 years. Our rate of childhood diabetes has gone from 0 kids having type 2 diabetes when I was a young pediatrician 50 years ago. And now it's half the kids with type 2 diabetes. Oh, this must be because people lack self-discipline because poor kids have more than this. Well, actually, it's much easier to get cheap, high-calorie food if you live in a poor neighborhood. And if you turn on the TV, I love this, you can watch other people be athletes. Well, the people making food spelled backwards are spending $5.5 million in 30 seconds to tell you to eat food spelled backwards. Kurt asked me what doof stood for. He thought it was a German word, but it's actually food spelled backwards. So, you know, I think the ultimate injustice is going to happen it's happening now, but it's really going to hit us intensively over the next 20 years. And it goes back to my point about the go bags and the fires. Fire reality and superstorms are the reality of this 21st century. And maybe during the Q&A, we can dive a little deeper. And thank you for your patience. And I'll stop there.
Well, my PowerPoint is being queued up. I have the privilege of going on exactly at lunchtime. And with presentations like this on a long day, I always try to identify something that will help mine to distinguish itself from the others in kind, not necessarily in quality. So I was searching around. My topic for today is the international regulatory design with respect to cancer-causing substances. Exactly at noon, not necessarily the catchiest title. However, I opened up the New York Times this morning, and what do you know, there was my answer in the form of an op-ed by David Keith, who is the generally understood as a professor of physics at Harvard and also at the Kennedy School, regarded in some quarters as the good life of geoengineering. He had the following to say about climate change, not about cancer necessarily. Since Boston College is about to send its first delegation to COP26, Glasgow coming up, it seemed to be appropriate as well. He says humans might make the planet Earth more reflective by adding tiny sulfuric acid droplets to the stratosphere from aircraft. Whitening low-level clouds over the ocean by spraying sea salt into the air or other interventions. Sulfuric acid, of course, in its long-range transport form, is exactly what we've been fighting for 50 years in the form of acid precipitation. Here's another sentence. Geoengineering might worsen air pollution or damage the global ozone layer, which we have been working for no less than 40 years to protect. Well, never mind that. It's all worth it. In fact, that's one of my examples is ozone in terms of regulatory design. And then this taps into the presentation. Geoengineering's grand challenge is geopolitical. Which country or countries get to decide to inject aerosols into the atmosphere, on what scale and for how long? He doesn't answer the question. There is no easy path to a stable and legitimate governance process for a cheap, high leverage technology in an unstable world. In other words, he offers no solution to the governance problem, which is what I'm trying to get you to think about today, what we as the instructors of the next generation of regulators and practitioners, and when I say we, I don't mean Queen Victoria, I mean those who are assembled in this room, Dr. Landrigan, Dr. Scheif, my co-instructor, Marianne Sherba, and others that are training our summer and others that are training our students every day. So with that in mind, you, as a somewhat disdainful background about the prospects of international regulatory design for cancer, I would invite you to look at the following, what I think are hopeful examples. International constraints are very different from
the domestic level. There's no international legislature, there's no Congress that can enact laws for the world. The Kyoto Protocol is oftentimes. Oh, okay. All right. Okay. The Kyoto Protocol is oftentimes described as a top-down process. There is no body that can instruct states to behave in ways other than that which they choose. So there's no international legislature. That's not the General Assembly of the United Nations meeting right now. It cannot boss states around, not to put too fine a point on it. There's no court of general jurisdiction. The International Court of Justice is in fact a standing arbitral tribunal, and there's no international enforcement mechanism. So those are very serious constraints. We don't have that here in the United States, here in the Commonwealth here, and we still can't get the job done. There's also difficulty with the downward drag of the so-called rule of consensus. If you think about it, in the upcoming COP26, the biggest emitters are first China, then the United States, then India. If one of them should walk out, as one did, we happen to be sitting in the territory of that state right this second, as one did, there's nothing to bring it back. So there is a necessity for consensus, meaning virtual unanimity among the 193 states on the planet. If one outvotes a state that is dissenting, the one thing you can be sure of is that that state will not participate in the solution. So, and then the slowest vote phenomenon, we're seeing that in the US Congress right now. Generally, the least common denominator and the slowest vote are the one that tend to be the rate determining steps, not to mix metaphors, in these policy areas. So what I'd like to do is to use two examples. One is hazardous waste, and the other is stratospheric ozone, and then to draw some general conclusions, and with the intention of staying strictly within my time. The first one is the international trade in hazardous waste. If you think about it, hazardous waste is not a good in international trade. It is a bad in international trade. It has negative value. It is harmful. You can also extrapolate these same principles to toxic pesticides and to industrial chemicals such as asbestos that was mentioned in the previous panel. So a very serious problem of surreptitious illegal exports of hazardous waste. This is one example from Cambodia. In fact, the government in Cote d'Ivoire literally fell over a hazardous waste scandal a number of years ago. Their Cocoa Nigeria, the Cayenne Sea, a boat that would not be allowed to make port in any country because it was carrying hazardous waste. A very serious problem of protecting the global public health, which is a commons management issue. Okay, so what the United Nations did in the form of the United Nations Environment Program was to come up with a convention in, now I'm really in bad shape, I think. Is this working? Okay, so in 1989, came up with a multilateral convention, which is the solution to most of these problems, called the Basel Convention, that first of all came up with a definition of hazardous waste, if you think about it, absolutely necessary. Here's the nature of the problem. 300 million tons of waste generated, 2% is exported, but of that, 90% is classified as hazardous. It's often very difficult to determine what's in this toxic mix, to reverse engineer as to where it came from. In the United States, we have legislation that requires a manifest, that requires a definition of what is contained in that 55-gallon drum, not necessarily so internationally. So a serious problem, and defining it is quite difficult. This is a nod from the United Nations Environment Program to Dr. Landrigan. The principal waste exported by volume was lead and lead compounds, but also carcinogens, such as pesticides, organochlorine pesticides. The 1989, a global convention, which is the theme here, a multilateral agreement. It entered into force, it was adopted in 1989, entered into force in 1992. And like many of these instruments, including, by the way, the UN Framework Convention on Climate Change, it is an umbrella framework that is intended to be an organic, living, breathing entity that goes on into the future. So under the Framework Convention on Climate Change, we have the Kyoto Protocol, we have the Paris Agreement, which are ancillary instruments, similarly with Basel. Interestingly, at the time that the Basel Convention was adopted, not a single sub-Saharan African country signed the agreement because it thought it was because the theory being that it was too weak. So it was a major innovation, but even so, did not necessarily address the needs of what you might think of as the progressive wing, looking at current US politics, the analog to the progressive wing of the Democratic Party pushing for even further at the moment. That is characteristic of many of these solutions. They are consensus solutions and somewhat middle of the road. Nonetheless, the Basel Convention has been very successful. It has, most states on the planet are parties. I am quite ashamed to say that the United States is not. In fact, the Senate bizarrely has given its advice and consent to ratification, but the industry has opposed the domestic implementing legislation. So the United States is truly exceptional on this, as many other issues. It is not a party to the Basel Convention. As with the Framework Convention on Climate Change, how does it work? Annual conference of the parties, a professional secretariat, which happens to be located in Geneva. And this is the primary regulatory design. It's called prior informed consent, which means something differently on the international level than it means domestically. The problem was surreptitious exports of hazardous waste that states of import didn't know about. How do we go in some direction to fix the problem? The answer is require the exporter to notify US EPA. By the way, the United States is actually implementing the Basel Convention. Bizarrely, the United States came up with this scheme in the RCRA amendments of 1984. It's been generalized internationally, and the United States is still not a party to Basel. Go figure. But in any event, the US EPA notifies the government of the state of import. And this is the prior informed consent piece. The shipment does not leave until the government of the state of import acknowledges receipt. By the way, I'll make this PowerPoint available to people if you want it. Acknowledges the receipt, and then and only then can the shipment take place. So prior informed consent, which has been a useful vehicle internationally in a variety of other areas, chemicals, pesticides. If you notice, there are so many different technologies here. There's a bit of a gap here on the with respect to the state of import and the importer, and also the public in the state of import. How are they informed? But at least this goes some way towards alleviating some of the problems. In addition, layering on top of that, there is what's called a partial ban, a limited ban, so that the United States does not get the benefit of being a party to the agreement because it cannot export under the Basel regime, nor can it import. And also an additional requirement that states of export assure that the waste can be managed appropriately in the state of import before it goes. So this is heavy duty regulation in the international area. Okay, second of all, stratospheric ozone depletion. I'm sorry, this is a cartoon that appeared in the Washington Post after then Secretary of the Interior Donald Hodel, during the negotiation of the Montreal Protocol, said, well, why do we need a protocol? Individuals should take personal protective measures, meaning hats and sunglasses. And my colleague at the Natural Resources Defense Council, David Doniger, quipped in the Washington Post, well, Secretary Hodel wants the entire country to look like the Blues Brothers. and he called it the Ray-Ban plan. So this appeared the following day in the Washington Post. The basic problem is that of a handful of anthropogenic chemicals, that is chemicals that are artificial, not found in nature, that are very long-lived in the atmosphere, very similar to the climate problem. They are, for those of you of my generation, you may recall that they were used as propellants in hairspray and in deodorants. At the bottom of your hairspray or deodorant, you still got the same oomph. No longer, because the substitutes are carbon dioxide, and the carbon dioxide wears down. Also, they are very useful as refrigerants. They work as heat pumps because they are essentially non-toxic. They're full, for those of you who are chemists in the room, they're fully halogenated alkanes and essentially non-reactive with biological systems, that is you or me. And second of all, they are easily compressed and expanded so that they operate very well as heat pumps. This is the mechanism of ozone depletion. Ozone, Professor Keith doesn't seem to care about it very much, but 40 kilometers above the Earth's surface is a very thin layer of triatomic, very unstable oxygen. And you have these very stable chlorofluorocarbons. Maybe this will, what do you know? All in one. Chlorofluorocarbons, very stable because of those carbon halogen bonds, carbon fluorine, carbon chlorine bonds, and they are literally blown apart in a chain reaction in which one molecule of a chlorofluorocarbon then goes on to destroy something like 10,000 molecules of ozone. All right, so that's the nature of the problem. One of the themes here, I hope, is that it helps to, it's essential to characterize the problem appropriately in order to craft an appropriate regulatory design. The United States and the European Union were engaged in negotiations over this for any number of years and had incommensurate legal theories. The US, having gotten rid of the aerosols, said the entire world should do that. The European Union put a capacity cap on the totality of CFCs. Economists love it. But the two of them could not be reconciled with each other. What in fact made the agreement go in the end was the discovery of the Antarctic ozone hole in 1985. I'm not getting the laser pointer, which scared everyone so much. It was on the front page of Time magazine that the parties agreed to a 2-year cooling off period and came up with a model that continues to exist as the framework for climate change. So first of all, a percentage reduction, a prohibition on trade with non-parties. If you think about it, the MEA is the Montreal Protocol. If Fredonia and Ruritania are phasing down production and consumption of chlorofluorocarbons, that encourages utopia to become a pollution haven. To say, hey, come and make more CFCs here, and you can export them from us to protocol parties. So a holistic regulatory design requires prohibitions on trade, and then, which has caused some difficulties in the World Trade Organization, and then a 10-year grace period for low-consuming countries. As I think the prior presentations pointed out, some of these interventions, such as refrigeration, are major public health requirements. So we can think of, I went to a presentation where a representative of the auto industry in the United States said that automobile air conditioning has come to be regarded as essential in the United States. I burst out laughing. I mean, how can something come to be regarded as essential, especially when there are places on the planet where people do not have access to refrigeration to store food? So this is what has come to be called differentiation, that states have common but differentiated responsibilities. All states have an obligation to participate in the reduction schedule, but those that have fewer capabilities, where the substitutes are going to be more expensive, have phased in later and less demanding obligations in dealing with this global commons problem. Okay, just one other point. All of these regimes are designed to be ongoing fora for further cooperation. If you think about it, you have to come up with a legal mechanism for doing that. And the answer that's given by international law is an amendment to the agreement, which, if you think about it, has to be a new agreement. And so you have the problem of classes of parties. What the Montreal Protocol did was to set up a new process by which new reduction schedules could be adopted by a supermajority vote and were binding on all parties. So yet another innovation, structural innovation. So the, let's see, I'm almost finished. The effect of the Montreal Protocol, the ozone hole over Antarctica, which opens during the Antarctic spring, which is now the Northern Hemisphere fall, will probably be healed by the end of this century, unless, of course, David Keith decides that we don't need to do that. But will probably be healed by the end of this century. This regime has been extraordinarily effective and is a model for all others, including climate, which has been less so. So there are others that have similar models: multilateral agreement, a forum for further cooperation, and ongoing evolution to deal not just with hazardous waste and air pollution, but others such as a particular substance, mercury. And then this is a shameless plug. If you're interested in what we think is the definitive statement of the International Law of Toxics, you can consult this myself and Noah Sachs. It's the Oxford International Handbook of International Environmental Law, hot off the presses. Be glad to give you a copy, or at least a copy of our contribution. So common themes. First of all, sustainability and intergenerational equity. The theme is that our generation, so I'm well within my time, our generation should meet the needs of those currently on the planet. On the other hand, as I constantly tell my global public health law class, we need to keep in mind the rights of their children, that is our current undergraduates' children and their grandchildren, so as to hand them a planet that is hopefully no worse off than it was when we got it. Looks like that's not going to happen, especially with respect to climate. On the other hand, I hope I've convinced you that we know how to do these things. It's a failure of political will. It's not that leaving myself aside, fine minds are not deployed on this. We know how to do it. Second of all, precaution. This is a heuristic that is common in everyday life. A stitch in time saves 9, look before you leap, etc. This is in fact the theory behind the drug approval schemes that were discussed on the previous panel. If you think about it, if Merck or Lilly comes with a new drug to bring it to market, the presumptive answer is no, or at least not yet, right? Until the drug can be demonstrated to be, first of all, safe, and second of all, effective. And that's determined by a third party. So that's an inherently precautionary scheme. The answer is essentially no until you prove safety. The other example that was given, at least while I was in the room, asbestos, is the opposite, right? Asbestos just entered the marketplace without, as did CFCs, without prior testing. The Europeans are working on that, and to a considerable extent are further along than we are on many of these regulatory design issues. And then the last is differentiation, common but differentiated responsibilities. This is why it took us so long to get to the 26th Conference of the Parties to the Framework Convention on Climate Change, because originally for a decade or a decade and a half, the world was preoccupied with reductions coming strictly from 33 industrialized states, including our own with market economies, and wasn't paying too much attention to the Chinas and Indias of this world. If you think about the learning from stratospheric ozone, the learning is to include all states in these global commons management issues from the beginning, and to have differentiation built into the system, as opposed to tacked on after the fact the way we're dealing with in the Paris Agreement. So thank you very much for the opportunity to talk to you a bit about international regulatory design, and I hope it leaves you with some common themes that you can take back to your own work. Technology that gets you.
Okay, can you all see my slides? Hopefully.
If you would like to share your screen with the full screen, please. Sedu, thank you.
Is that good?
Yes, perfect.
Perfect, thank you. Hello, everyone. Thank you so much. I'm honored to be here, and I also appreciate the invitation. I've worked with Drs. Landrigan and Dr. Jackson for easily 2 decades now, so it's a pleasure to be here and help participate. I'll be talking about the role of policy and prevention as we think about protecting people in our environment. And again, my background is maternal and child health, so that is the lens from which I come. Those of you that are just getting to know the Children's Environmental Health Network, we're a national nonprofit. We've been around almost 30 years. Our mission has always been to protect the developing child and fetus from environmental hazards while we promote a healthy environment in all places where children spend their time. That's learning environments, homes, schools, early child care, and parks and whatnot. For the last almost 30 years, we have been working to stimulate prevention research, to translate the important research that comes out a variety of fields that means so much to our field of work, to then educate and train, build awareness, and of course, help to work and empower in partnership with our community leaders. And of course, we're working for child protective policies at the federal level. Our office is on Capitol Hill in Washington, DC, so we're very busy at times. And then of course, contributing to state and city level policy as well. The field actually began, I'd say around the late 80s, and the Children's Environmental Health Network was one of the first organizations to start articulating the need to protect children. There was a blueprint at that time that in essence started the field. For the first time, policy leaders talking to farm workers, talking to environmental justice leaders, talking to researchers and advocates. Well, a few years back, we kind of went back and reassessed the blueprint and had additional players, additional perspectives, communication experts, legal experts, health economists, engineers, also at the table with us to have this renewed blueprint for protecting children's environmental health. We call it an urgent call to action. And it is used to help assist all of us. It's on our website, cehn.org, to assist at a high level when we think about prioritizing this very advanced field, but there's so much in the field to cover. So you need to prioritize and narrow, especially when you think about limited capacity. And obviously, we're also talking about the need for policies and standard settings. Social determinants of health and the lens of justice and equity are seen throughout and certainly prioritized. These are the overall themes. We need to mobilize society, as we've been talking about, to take action, placing a strong priority on where the vulnerabilities of children are, especially those even highest risk within the child health population. We need to create essential knowledge. It still is amazing to me how many people are out here. It's increased certainly, but still are not really understanding the connection between one's environment and our onset of health, whether it's positive and or negative. And then marshaling the engine of the economy to achieve environments in which we want children to be able to thrive and have a positive educational journey, be able to focus in on their education and enjoy with full abundance the entirety of their lives without disease and harmful impacts. And then of course, building the political will in our institutions of government and beyond. So I'll focus more on these last two for the remainder of the talk. Of course, it goes without saying, but I will say it, that inequities must lead all of our solutions. We have seen far too many times when I'd say well-intended efforts, come to find out policies when enacted, come to find out that they were really missing the most highest risk, the most vulnerable. That just cannot be. those children who are living in lower wealth communities, those populations of color, and many other desperate social determinants that put children at risk and their families. They just cannot afford at times and have the capacity to just pick up and move when harm is detected, or the COVID-19 pandemic has completely leveraged the reality that not all of our schools are equal as well. Ventilation systems are extremely important, and investing in them well before, a situation like we're in would have been great, but not all schools have that luxury. And then just elevating how important it is for parents to go to school. And that means childcare facilities need to be open, accessible, affordable. All of this has been very interesting to watch because we've been in this, understand these realities for a long time, but it seems like a lot of the rest of at least our nation is catching up. The traditional approach to environmental health laws and regulation is that, we've been waiting for children to get sick or that are vulnerable to get sick. And then we try to go back and figure out, well, what was the culprit? What were they exposed to, especially if there's a cluster situation? Waiting for evidence of harm, placing children at risk in any vulnerable population is putting them at risk for lifelong, irreversible, and preventable damage. That's really what gets me. Much of this is preventable. So some of the ways that we've been working and trying to lead to help implement and mobilize the engine of the economy, and to call out the realities of our dependence on fossil fuels and the production of synthetic chemicals for many decades now. One of these examples is the Cancer-Free Economy Network, which is a systems approach. It's a fascinating process. If you haven't had a chance, we took a good 2 years to be very thoughtful and to do some very in-depth, facilitated discussions where we were looking at the whole systems of the ins and the outs, the inputs and outputs of how we've gotten here, and where could 60, 70, 80 now, I think, groups with our various expertise and perspectives lend and really impact the reversal or adjustment of that system so that it truly is preventive and protective. So our guiding star is that within a generation, we will lift the burden of illness and cancers and other diseases by driving a dramatic and equitable transition from toxic substances in our lives and communities and economy to safe and healthy alternatives for all. We took a while to also figure out how to best organize ourselves. So we have a building power segment of our work, really making sure that we're not seen as coming into communities as though we have all the solutions. It's actually far from that, but that we are actually in unison, in partnership with communities, acknowledging the decades of work that many environmental justice, community-based oriented groups have been trying to leverage and lift up and strengthen the wonderful evidence-based work that they are doing, bringing in more capacity for them and doing what we can to help them and communicate their narrative. Communications is huge. The telling of the story, as we've been hearing, changing the narrative. Majority, as also you've been hearing, of capacity and money in the US, at least, is going towards cancer treatment, hardly any towards cancer prevention. So we need to be balancing out, the capacity as well as the discussion around it. I'm part of the health science team with the University of Massachusetts at Lowell Center for Sustainability and the Silent Spring Institute and the Alliance of Nurses for a Healthy Environment. We are the backbone, if you will, of this because we realize that it's the science that we can lean on that is showing us the indicators that prevention is possible, and also demanding and encouraging the additional gaps of science be fulfilled and addressed. Shifting the market. So we need to be creating a demand for the supply of healthy alternatives and no more with the regrettable substitutions. So a high emphasis on green chemistry and the jobs that will come with that and the innovation. And of course, policy, legal, we have a big distinct effort in policies and legal strategies that communities are already implementing that we want to leverage. So we work together. Yes, we have these buckets of areas of work, but it's very important that we're cross-sectoral in our work. So designing interdisciplinary resistant type of solutions that are accelerating, in our upstream and are not waiting again for people to get sick and are cutting off the exposure before it even happens, building more champions and mobilizing when we've had success, policy standard success in the US and beyond. It's when we have the numbers, when we have people standing up saying no more, and the resistance is very clear. Coordinating our supply and demand strategies and thinking about the impact and the narrative that we are looking for, that generations require and are deserving of. And we have also created a policy agenda that puts the most impacted by toxic chemicals at the front line. And we provided this to the Biden administration the first week in office. So Catherine Alankar, who's the director of the Center for Environmental Health and also is part of our policy legal team at the Casa Free Economy Network, said that there's a great need to fix the damage done to the public and the environmental protections during the previous administration. There were many rollbacks that have been of much concern to all of us in any of the advancements that we've had, even though we agree so much more needs to happen. But there's even greater need to go beyond repairs and build a regulatory structure that frees all people from the burden of toxic exposures that increase their cancer risks. So we also have this resource that was passed along, and we're trying to work with the current administration, a path to cancer prevention, and acknowledging the inequities. The same generations of systemic discriminations that have ruled in Black and Brown communities, disproportionately suffering from the COVID-19 pandemic, are also those that are driving the stark racial inequities in several types of cancer. Another example of where we are working to mobilize the economy and lift up the political will necessary is through the Childhood Cancer Prevention Initiative. Last September, we released the first ever report on childhood cancer prevention, which identified existing peer-reviewed science that is showing us the trends of where that increase in incidence of childhood cancer since 1975 has been coming and where there are many associations. Our aim is for the first time to have childhood cancer focused organizations and advocates, public health advocates, health professional associations, faith leaders, sustainable business, and researchers together working to create awareness of environmental connection with the diagnosis of some forms of childhood cancer affiliation. We make a strong business case and economic case, which it's been exciting to also hear a lot of those being made today. And we work to create those actions and those solutions, community-oriented solutions, to advocate for public policy and lifting up examples that are happening all over the country. These are just a few of the leading collaborators for the Childhood Cancer Prevention Initiative, and we are certainly growing, and we encourage anyone interested to check us out and learn more about us. Again, as you've heard, the childhood cancer rates have been steadily increasing since 1975, and as Phil Landrigan mentioned, that is, we cannot equate that to genetics only. There's definitely a variety of things happening in the environment. What our report does identify is that the trends we are seeing is that exposures to pesticides, near traffic air pollution, paints and solvents is a big part of the culprit. So we do believe that we can actually prevent many forms of childhood cancer through changes in our business and in government and policy practices by producing and purchasing safer chemicals and products and putting the onus and responsibility on those that are utilizing these chemicals in their products, to invest in prevention research, to advance public policy, and to incentivize safer chemicals and products from the very beginning, to support and expand regulations and reduce known causes. And that's our website. So when we look at systemic change for prevention and looking at policy, we have to lean on where we've been in order to, be more effective and efficient into the future. We do know that ideas that were once controversial are now expected. For example, kids' stuffed animals used to be filled with oily rags, and now they're filled with fresh, clean fill. Products that were made for babies and toddlers do not include small parts anymore to avoid them choking. New York City does not look like this picture or the picture that Phil actually brought up. We definitely still are dealing with all kinds of air pollution, as we know, but we are getting better than we've been decades before. Car seats, car restraints are reducing morbidity and mortality related to, motor vehicle accidents. And as was discussed earlier, this is of course a big example in the children's environmental health field where a variety of these public health actions definitely have reduced by 95% or so children's blood lead levels. I would also add that we are not there yet. This is a totally preventable type of exposure. I definitely get on my soapbox about this one. So a lot of us are still working very hard to close this gap. We do know that exiting progress is at risk, right? So even by the time this slide was made, there are over 100 environmental health laws and regulations from the ending time of the Trump administration that have been in jeopardy or proposed to be rolled back. And many of them related to our basic air, water, infrastructure, and other types of exposures that any of us and our families will come in contact with each and every day, which is extremely concerning. So governments must fulfill their obligation to prevent cancers of environmental origin by protecting existing and recent federal laws from rollbacks, which I know is in active play right now. to hold the US Environmental Protection Agency accountable for enforcing existing regulations. That's also capacity to do that is a big challenge as well at the local level. Expanding air quality and water protections. There are still places in the United States that do not have access to clean, accessible water. They're relying on bottled water. That's not good for our environment. That's certainly not an economic, sustainable practice. Requiring and it's also inequitable. Requiring the reduction or elimination of pesticide use. So we've had, some wins, and we want to acknowledge those. California, Hawaii, and now as of July, New York have banned the use of chlorpyrifos. We've also had a ban in New York, glyphosate and Roundup and any glyphosate products were banned for use on federal lands in New York. That was also just this last year, which is exciting. And I will note an equitable reality there is that many families, especially low wealth families, when they're living in an urban environment, the only green space they may have is their city park. So the injustice of being sprayed or being exposed to Roundup or a very awful neurotoxicant like glyphosate is definitely an injustice. And groups like the Black Institute and Beyond Pesticides and many other community groups have rallied to make sure that their communities are better protected. And I believe we will see more of these, which is good. And also the EPA, after a lot of pressure from advocates just in August, finally banned the use of chlorpyrifos for food uses. So that's about 80% of its use. But we do know that about another 20% are non-food uses. It's our understanding that those uses will be up for review by the year 2022. And the hope is that they will also ban for that use as well. And also requiring the use of safer materials in children's products in our built environment and eliminating toxics from their source. That's really where we need to be. We also need to be using government and institutional dollars to purchase non-toxic options to ensure that children's spaces are sited safely. We have a whole project on safe siting that we work on with the Agency for Toxic Substances and Disease Registry. Unfortunately, there have been too many cases where a childcare facility, for example, is placed on an old mercury a chemical plant, and children even decades later are feeling the negative health implications from that. So we have to do better there. Requiring transparent disclosure of chemicals of concern in products. Some of the most frequent questions that we receive from the public is, I'm on board, I get this, I'm appalled, I want to do better, I want to be a stronger advocate. How do I even best be an effective consumer? Because many times labels won't tell you much, or they'll send you to a website in this day and age. And most of us, I'm a mom of 4, do not have the time or the energy to go to a website when you're in a store just trying to get what you need and move on with your daily activities. So we have to do better there. And increase funding for research on cancer prevention, as we've been talking about, and to completely much better balance out where capacity currently goes. We need treatment, but we also need to balance out capacity for prevention. The bottom line is that government has a fundamental obligation to provide for the general well-being of the public and our shared environment, both of which are profoundly at risk due to the ways in which chemicals are manufactured, used, and released. And policies that restrict harmful chemicals and drive our economy towards safer solutions are essential if we truly are serious about preventing deadly diseases like cancer. And just my plug real quick, Children's Environmental Health Day, we started 6 years ago. It's always the second Thursday of October, which will be October 14th this year. It's all virtual. We also have activities throughout the entire week, so please go. There's a lot of room for additional partners and a lot of great ways to network. It's a day of action for and with children and assessing how we can all be better in protecting their futures. Thank you very much.
Thank you. Thank you very much. I'd like to ask our 2 live panelists to join me up here at the front table. And we have Ms. Witherspoon on screen. So I'm very happy to field any questions that you'd like to offer. Yes.
Thank you. Yeah. Excellent presentations. All speak to the question, how can we improve prevention? And my question is to David, and it's a very difficult, tough question. So you briefly mentioned the Rotterdam Convention, and we know since long and very strong evidence that asbestos causes cancer and many other diseases. Still, Russia, the biggest exporter of asbestos, has not agreed to the Rotterdam Convention. And this is only about prior informed consent. So it wouldn't be a ban, it's just informed consent when exporting. How can we overcome this issue of the need for consensus, or what you call the least common denominator? Is there any kind of legal perspective that you could offer? I mean, here it applies to the Rotterdam Convention, but it also applies to the COP26, it applies to the UN Security Council, etc.
Right. Just as a little bit of background to Dr. Schreif's question, the Rotterdam Convention is modeled essentially on the Basel Convention that I was talking about with respect to waste. So,
You on?
It is modeled, the basic workhorse, regulatory workhorse of the convention is prior informed consent, so that you can basically import everything I said about Basel and apply it to his question about asbestos. These problems do have solutions, and again, I will say that the difficulty is lack of political will rather than lack of expertise in terms of how to structure these situations. So, for instance, if you look at a different specialized agency of the United Nations, the World Trade Organization, there are in fact dispute settlement procedures that are very frequently used that are very powerful. In fact, that's one reason why our previous president basically eviscerated the WTO. So the states do not like to be held accountable, and one way every state that is going to the Conference of the Parties on Rotterdam will look at the Russian Federation, but any state in that situation, and say, well, you know, that could be us. And so they are reluctant to craft genuinely effective response mechanisms because they're afraid of being on the opposite side. And in fact, what we're seeing, unfortunately, is a dilution of these mechanisms, particularly on climate. The Kyoto Protocol had it's now expired as of the end of last year. The Kyoto Protocol had a very effective enforcement mechanism that in fact led to Canada's withdrawing from the Kyoto Protocol because it could not meet its obligations under the instrument, because it chose to exploit the Alberta tar sands, which are very energy intensive, as opposed to living up to its -7 obligation under Kyoto. So hopefully activism by the next generation, Greta Thunberg and others, will lead to putting in place mechanisms that have some vigor behind them. National states can also reinforce mechanisms. So, for instance, with respect to fisheries, there are domestic measures within the United States, the Pele and Packwood amendments that allow the U.S. government to punish states such as Japan that engage in violations of the Whaling Convention. So the models are out there. They require more political will to ramp them up, make them more regularized and more effective.
Great, thank you. Any other questions? Yes.
Thank you. Has there been any of the poorer countries in Africa or in Latin America or in Southeast Asia that have signed up to any of these conventions?
I'm sorry, I didn't quite get the end of the question. Have signed up to do?
To the conventions.
To the conventions.
Oh yeah, well, the purpose of both the two regimes that I was talking about are United Nations regimes. They're adopted under the auspices of the UN. They're therefore what are generally called universal. They are intended to include all states on the planet. One of the problems with the climate regime is that at the beginning, it didn't, and we lost maybe 20 years because of that. So the challenge is with respect to the global South, which is what you're talking about collectively speaking, is the question of differentiation. So what are appropriate are appropriate obligations, what are appropriate mechanisms for meeting states where they are. Part of that includes funding. In the case of, say, hazardous waste, it includes beefing up customs services so that states of import can have some sort of surveillance about what's coming into their borders. The United States is tolerably good at this, but other states are not. So technology transfer, international support in terms of just finance. So for instance, in the climate area, all of these agreements have associated funding mechanisms. The big one that applies to almost all of them is the Global Environment Facility, but there are others, such as the Green Climate Fund, that applies specifically to the climate situation. So yes, we also know how to do that one, which is to meet states where they are, identify their needs, and getting back to Dr. Streif's question, not necessarily to punish them, but to help them identify obligations that they can actually live up to and to help them meet them if they, so just one other point is some of these compliance mechanisms actually allow states to self-identify as being out of compliance. You would ask, well, that sounds bizarre. Why would a criminal identify himself or herself to the authorities? Well, the answer is, well, then the purpose of them is not to punish. The purpose is to assist in maintaining these global commons. I mean, we're really talking about global commons management in almost all these situations. So you have to get out of, I'm not saying you, but one has to get out of the sort of municipal, domestic way of thinking about things and look at the unusual constraints of the international.
And you'd like to jump in too? Is your mic on?
So I've been often asked by students, what should I think about and how I'm worried about the trajectory of the world, the planet, global heating, et cetera. And one of a real disaster over the last 4.5, 5 years has been the coring out of the US State Department, and an awful lot of very motivated people, a lot of them with deep experience, have left. And I have strongly suggested to students who ask me that, and a lot of them are interested in global affairs, in law and other things, the State Department service is extraordinarily important. It's not glamorous early on, but the complexity of the things you deal with is endlessly interesting, and you can have a real impact. Sometimes you don't think anything's going on, and the door opens up, and the things you wanted to fall in place happen if you've articulated the right terms. So it's so easy to become discouraged about the state of the world, and everybody's got to pick their one thing and work hard on it.
We've got time for one more question. Yes.
This is a question for Ensei Witherspoon. Ensei, thank you for a lovely talk. One of the things you've done very effectively, and you illustrated it with your talk about the cancer-free economy, is that you've succeeded in bringing the business community to the table and somehow cutting through greed, or at least minimizing it. I want to ask you if you could take a minute and tell us how you did that, but let me add a further nuance before you respond, and that is we have a business school at Boston College, a very well-regarded business school. I think we have a couple of people from the Carroll School of Management, as it's called, here in the audience today. How do you advise businesses, and how would you advise students who are thinking about careers in business, how to combine ethics with the imperatives of business itself?
Thank you. A really good set of questions. So the American Sustainable Business Council is one of our strong sustainable business partners at the table at the Cancer-Free Economy Network and Childhood Cancer Prevention Institute. There's a lot of sustainable, forward-thinking businesses within their network alone. Their aim there is to utilize their platform to then bring in others and identify the myriad of motivations as to how and why certain businesses would want to come in. Now, the slide I think that Dick Jackson put up with the salaries of the CEOs of different insurance companies and other healthcare companies. Okay, so they're not at our table yet, but it doesn't mean that they have to be so far off of our agenda. Right now, we're, the low-hanging fruit, if you will, are those B Corp organizations and those organizations and those businesses that already have a business model that understands their bottom line actually benefits when our public is healthy and whether they're a part of that, including their personal responsibility that they hold for their employees. A lot of exposures do happen on the job. So occupational exposures and these cancer and many times preventive exposures, especially women of childbearing age, working and or pregnant women, this is all concerning. And forward-thinking employers understand not only the liabilities potentially that they assume if they don't protect harm when otherwise they should know better and do have evidence to know better, but also the moral authority. We will continue to expand this net for sure. These are kind of the, again, organizations and businesses that very much understand the economic benefits and have a decent sustainability core in them. And as we outreach, those challenges will certainly grow. But the benefit that we do have is, again, the business case, the economic case, the public health case, and then the moral case all in our favor. So they can work as hard as they want to break those down, but those facts do not lie. And I know, Phil, you brought up a lot of those economic reality slides as well. On the case of our wonderful students out there, it's been, while there's also been a gutting of the EPA, I would also add, from the last administration and other federal agencies and state agencies, the COVID pandemic, as awful as it continues to be, there have been silver linings in that public health, environmental public health is being talked about more than I ever remember. Toxicology is being talked about. And a lot of students are gravitating towards either thinking about dual degrees, public health and law, public health and medicine, ethics, social impact, built environment. I mean, you name it. It's really, it has always been of interest and a growing interest, but it's really skyrocketed in our public health. Those in public health academics confirm the number of applications flooding in, the number of students deciding to take gap years before they go to med school because maybe they want to go get their public health degree and understand an environmental link to that. So I would just encourage you to do what you can to set the course, acquire the type of courses and the type of degree that's going to work best for your passions. There's more than enough work out here. There's more than enough of us that want to work with you and also very much welcome your creativity and your innovation. We need as many forward-thinking people as possible to get to these solutions.
Thank you. Well, we have our charge for the rest of the afternoon and indeed for the rest of our lives. So on that note, I'd like to ask you to join me in thanking our distinguished panelists and move on to poster session and lunch.
Thank you all. We have lunch available now, and in the Boston room, 5 posters of students who have been selected, and I encourage you to visit the posters and engage the students while you are having your lunch, and see you at 1:30.
Apropos of your comment, I actually started my career